Without any one member of that team, we are not a team. But that's how we function. We all function together, and we think of ourselves as a unit. Okay, maybe not an orange or apple or whatever, but we all think of ourselves as a unit. And the most important person in that team to us is who? It's not me. It's not the physician. It's the patient and their family. And we really believe that. Okay, it really is the patient and the family. Who's the most important member. Of that team, and we're constantly engaged with these patients. Okay, we're engaged with them from the very beginning till the very end. Okay, we're always asking. And one way that we know that we're engaged with these patients is that we will never look at a burn survivor and look at those scars and say, "Oh my gosh, look how hideous they are," or "Look how disfigured they are." We don't think like that. And the reason we don't think like that is because we are engaged with our patients. Okay, we are in touch with our patients. If you weren't engaged with your patient, yes, you may think like that. Okay, we are engaged with our patients. We know our patients. Okay, we live this life that they live a little bit alongside with them. Okay? Now, how do we approach situations? So, new admissions. So, when a patient comes in, there's a couple of issues that arise. Okay, first of all, do they have capacity? And I would argue that for the vast majority of our larger burns, those patients don't have capacity. Okay, and an easy way to show that, okay, if you look at classic medical literature, surgical literature, right? The classic surgical dictum, okay, for the management of a trauma patient says if they have a broken bone or something else, you need to completely unclothe or declothe the trauma patient, make sure there's no other injuries, right? And a patient may come in and say, no, it's okay, my arm's just broken. That's the only thing that hurts. That's the only thing that's wrong with me. But we don't know that for sure, right? And the reason we say that is because that arm injury is a distracting injury. Okay, it's something as little as a broken arm that can be a distracting injury that can take you away from knowing or realizing that there's other potentially life-threatening injuries in that patient. That's just a broken arm. How can you tell me that someone with a 40, 50, 60, 70, 80% burn, that is not a distracting injury and that they have capacity to make decisions they can't? They're under so much duress. These are physiological changes that their body's going to undergo for years and years and years. And we can't expect them to have capacity at that very moment when they've just been burned and they don't realize what in the world is going on. Andrea didn't. Okay. Our approach to these new patients is we approach it from a team. We meet with the patient if they can be met with, or their family members. We go over the details of their course of hospitalization. How long are you going to be? How many surgeries might you have? What are the potential complications? What to expect? Where might you go? We answer all of those questions. And once again, it's not the physician who's meeting with these patients, okay? It's the physician, it's the advanced practice provider, it's our nurse, it's our charge nurse. Very frequently we have one of our therapists there, and very frequently we have one of our social workers there. So there's everyone involved from the very get-go for these patients who just come into a burn center. Now granted, there are cases where treatment is futile, okay? I will accept that. I mean, if we have an 80-year-old grandmother who comes in, house fire, and she comes in with 70 or 80% burns, that is not a survivable injury. Okay, we know what's survivable, we kind of know what's non-survivable, or we kind of know what's survivable, we kind of know what's non-survivable. That's not a survivable injury. Okay, and yes, we will proceed with, comfort care measures, or in certain situations, withdrawal of life-sustaining support. We'll proceed with those. But we recognize medical futility. We absolutely recognize the medical futility. And the interesting thing about the medical futility in burn patients is what? This is the only profession in which we have to go and tell a patient who is awake and can comprehend that you will die in 1 to 2 hours. There is no other person on earth who has that task or who has that job other than the burn team. And I cannot tell you the number of times that we've had to do that. In fact, I remember every one of those episodes very vividly in my mind, where I have had to go and tell the patients themselves, they're awake, they can comprehend, they understand exactly what I'm trying to tell them, at least we think they do, that they're going to die in 1 or 2 hours, that there's nothing that we can do to save them. Okay? Pain management. Absolutely, pain management is big. I mean, I would not come up here and say that, hey, I don't care about anyone's pain. It's not true. We absolutely do care about patients' pain, but all of you know what's going around in the media, right? I mean, you have addiction things to worry about, you have the cost of pain management to worry about, all these other facets of pain management that we have to worry about. And as with everything in medical care, right, it's a balance. Okay, there's a distinct balance in this. We try to manage their pain as best as we can, knowing that at some point we're going to cross the threshold where the pain management actually becomes a risk spend. And we have to maintain that balance. That balance is very difficult. It's not defined, and it's very difficult to maintain, but we absolutely do try to pay attention to it. When we round on our patients every day, there's 2 questions that we ask about pain management every single day for every single patient, okay? And those 2 questions that I ask to the team is, number 1, what is their pain management like during the daytime? Do we think it's adequate? What is their anxiety level during the daytime? Do we think it's adequate? Number 1. Number 2, what is their pain management like during the dressing changes? Do we think it's adequate, or do I need to go up higher? And if I need to go up higher, then any risk to that, outweigh risk and benefits. Those are 2 questions that we ask every day for every single patient, okay? Now what about consent? There's multiple facets of the consent. We absolutely agree with all the facets of consent. And then we also do give our recommendations for naturally during the consent process, but we don't need to talk about that in a whole lot of detail. But there is the consent process involved. A lot of some places may adopt a model where you have one consent that covers multiple different surgeries. We don't necessarily do that. We do try to get consent for each and every procedure, just to ensure that we have discussed it with the family and discussed it with the patient about what they're going to undergo, make sure they're very informed. Every procedure, granted, though it may be a little similar, there are some things that are different with all of them. And then what about end of life? Absolutely, we deal with end of life issues. You have a patient that seems to be doing well, and then all of a sudden things change. We've ran into some of those situations just recently. We've had some patients that thought they would survive their burn injury. You give them a chance, you realize that things are not going in the in the right direction. You sit down, you have a talk with the family members. We all agree that this is probably not the road that the patient would want to go down. And so absolutely we employ end of life decision making in a process into the management of our patients. Okay, and like I said, if we need to, as I said earlier, if we need to, absolutely we'll institute comfort care measures and withdraw life-sustaining support and whatnot. Okay, this isn't a victory for us. I mean, this isn't something where let's keep the patient going as long as we can because it's a victory to us. No, a victory to us, okay, is making sure that the patient is comfortable, that they have a recovery, and they have a quality of life afterwards. That's what I want to see. Okay, it's the same thing I tell all of my patients, right? They say, "Doc, how can I ever thank you?" or whatever. No. You don't need to thank me. The way you thank me is you walk into my unit and you walk on your own 2 feet and you interact with everyone. And I want to see you clear, coherent, and walking and moving around. That's what I want to see. That's a victory. Okay? That's what I want to see. And then let's go ahead and pause there, and I'm going to turn it over to Monica.
So I have been accused by some colleagues of drinking the burn unit Kool-Aid. So I'm aware of this accusation. I like to liken what I have experienced in the burn unit as drinking the kale smoothie. Because I actually think what they're doing there is good and it's healthy. And instead of thinking that we have to look outside the burn unit and import ideas into it, I actually think we should be looking inside the burn unit and exporting ideas. I think a lot of what they're doing there is very good work, and other units could learn a lesson from them. Hopefully what you'll see through my presentation, though, is that I'm not in hook, line, and sinker. So you can let me know after we're done if you think that I have drank the Kool-Aid or if I have drank the kale smoothie. So let me tell you a little bit about the history of our relationship, the ethics relationship at Metro with our burn unit. So the person who started our burn unit at Metro was actually the first physician to chair the ethics committee. And for about 20 years now, the Case Western Bioethics master students have been observing in the burn unit. So they come in on a particular Thursday, they go to bedside rounds at 7:30, at 8:30 they sit in on the interdisciplinary team meeting, then they chat with Dr. Fratt, who started our burn unit, Dr. Fratty Ann, and then at 11 they attend the adult burn survivor group. So for 6 years, we have had consistently an ethicist from the Center for Biomedical Ethics at Metro sitting in on the 8:30 interdisciplinary rounds. So it's been myself, Bern Esplin is here. When she served as a fellow, she sat in on there. A couple of our other former ethicists have also sat in on those rounds. When we started these 6 years of sitting in, it was 2011 when I actually started at MetroHealth. And what I thought about burn units can be summed up in 2 words. One of them is DAX, and the other one of those is paternalism, right? So I thought what I was walking into was a unit much like the way treatment was described by Schirokauer, and I thought that I was walking into an extremely paternalistic burn unit. And I thought this to the extent that when we sent our master's students in there, I prepared them for this experience. I told them, now, when you go into the burn unit, you're going to see they're really paternalistic, and you'll have to think about whether this is appropriate or not, and we can talk about it when you come to your precepting group. So I actually set them up for this belief about the burn unit because it was a belief that had been ingrained in me. And it's kind of no surprise that I felt this way. I'll get to how this sort of came about later, but we've done some preliminary research thanks to our research assistant, Rosie, over here. She's done an enormous literature review, and we've categorized these articles, our preliminary version of this research, into a number of categories. So we've categorized them into fertility and end of life, discussion about the burn unit, and of the 24 articles we found, one of them was supportive of the way patients are treated in this way in the burn unit. 7 of them are critical, and then the other ones, are just basically a discussion of what's happening there. With respect to autonomy, there were 20 articles. 2 of them were supportive. 11 of them are critical. Talk about DAX, there were 11 articles. 1 of them was supportive, 6 are critical. We talk about just ethics and burn treatment category, there were 9. 4 of them were supportive, 5 of them were critical. With respect to informed consent, 2 were supportive, 2 were critical. So you see the literature is overwhelmingly critical about what's happening in the burn unit. So let me tell you what I've witnessed since I've been there. It's not what's described in those critical articles in the burn unit. Patients do not actually refuse treatment in the burn unit. I've never heard of a case of this. So at Metro's burn unit, there are 200 patients about admitted on a yearly basis. So over the 6 years that we've been there, we've had about 1,200 patients, and this is just admitted. This doesn't include those who come through the clinic. All right, there are a lot more of those. The number of patients I've heard of refusing treatment is 1, and it was this year. And we have concerns about his mental health status at the time that he was refusing.
So what do you call refusing treatment?
He was saying he wanted to die. He just leave him alone, let him die. Physicians in our burn unit don't treat patients against their will. Again, patients are generally not refusing treatment, or mostly, or rarely refusing treatment. And there is good reason to believe, as Dr. Khandelwal pointed out, that patients acutely do not have the capacity to understand what's happening to them in the burn unit. There was a small study done. It was only of about 8 patients. These individuals had severe burns. And the study was done and asked them to weigh in on whether or not they felt they had capacity early in their burn injury. And all of them said they did not have capacity early in their burn injury, that the physician should actually be making decisions for the patients early in their burn injury because they don't understand what's happening. And it isn't until well into their recovery that they actually understand what's going on with them and can participate in decision making. And once they are autonomous or have capacity, they don't refuse. They want to continue with the treatment and get as well as they can possibly get. Physicians in the burn unit do not provide medically non-beneficial treatment. So the patients or surrogates give input into what they feel is an acceptable quality of life. And if between the team and the patient and or surrogate decide that the quality of life will not be acceptable to the patient, then discussions about end-of-life issues happen. The physicians are not afraid to have these conversations. They don't turn away from these conversations. They don't refuse to have these conversations. As Dr. Khandelwal pointed out, patient pain matters. Now, I only go to the weekly meeting. I'm not in the unit every day like they are. And as I was talking to them about this slide, I said, well, every week I hear you discuss this. And they looked at me and said, every week, Monica, we talk about this every day. Okay, point out. Okay, you talk about it every day. I'm only there every week. But they talk about whether they should treat it with pain medication, whether when they're doing a dressing change, they should do it under conscious sedation. And Dr. Khandelwal has recently purchased for the burn unit a virtual reality system which will help distract the patient during their dressing changes so that they aren't focused on the dressing change and on the pain they're experiencing. physicians are deeply engaged in patient care. So an article that was written in 2014 by some of our colleagues in another institution said that physicians are not engaged in patients the way they should be. This is just false. We were at a meeting about a year ago. There was a young gentleman, I think he was in his mid-20s, who had been burned. I don't remember the cause of the injury, but his hands had been burned. And while we were at the table, Dr. Khandelwal, in fact, noted, this was, I think, July or August, and they said, you know, Dr. Khandelwal said, he's getting married in October, so we have to make sure his hands are better by October because he wants to play the guitar at his wedding in October. Now, this came from the physician. It didn't come from the social worker. It didn't come from the nurse. The physician knew that this was his patient's goal. And this is just one example. So the team approach, everyone, in fact, has a voice. And at Metro's burn unit, these people are not afraid to use it. All right, as Andrea pointed out with Tammy fighting for this other way of treating her scalp, they will voice their opinions. So we have the Tammy example with Andrea. And Tammy does not do this just in cases like this. Tammy is not afraid, as Dr. Khandelwal will attest, to telling the attendings when they're wrong, and she's not afraid to do it in front of the entire team. But neither is the pharmacist. So I've heard the pharmacist regularly correct the attendings at the team meeting saying, no, that's not right, those numbers aren't right. And the pharmacist told a story, one of the soon-to-be former director of the burn unit is about to retire, and the pharmacist was telling the story about how, you know, he will say in front of residents and everybody, oh, you know, I got it wrong, she got it right. We should listen to her, she knows what she's talking about. So there was a patient on the unit probably a year or two ago who had a wound. It wasn't a burn, it was a wound, and he also had cancer. And when we got around the table to the nutritionist, instead of talking about what his feeding should be, she said, I just have to ask, are we doing the right thing with this patient? Are the benefits actually outweighing the harms with this patient? And should we actually continue treating this patient? And the attending looked at her and said, these are good questions, and we're thinking about this. Right now we think that they do, but there could be a point where we should stop because the harms will outweigh the benefits. Unless you think I let them get away with anything. Dr. Schirokauer and I have heard this comment from Dr. Khandelwal on a number of occasions when we question what he's doing and why he's doing it and why he thinks this way, right? So I remember the first time this happened, I think, was the third case that we worked on together after you'd gotten to Metro, and it was a gentleman who needed an amputation, and his sister was assisting with decision making. He didn't have capacity. And you were actually standing sort of a little down the hall. I was at the nurse's station. We had just called the sister, and you had started to get up and walk away. And you said, well, look at, and this will come up later, we handle things, we want them to survive first, and then we worry about function, and then we worry about what they're going to look like. And I looked at you and I said, but is that the way you should be doing things? And you looked at me and you said, I don't know. I've never thought about it. And then you said, you're going to cause me to give up medicine. I can't name the number of times I've heard that comment since then. So, you know, I may have drank something in the burn unit. I don't think it's the Kool-Aid, because we do question what's happening there and whether this is the right thing to be doing. And part of this presentation, as you'll see as I finish, is to encourage you to come with us and help us question what's going on in the burn unit so we can provide better care, so the surgeons and the nurses and the social workers, so that we can provide better care to these patients. So in 2014, you know, we met Andrea, and as has been pointed out, there was a disagreement between her father and her friends about who should be making decisions and what those decisions should be, and the team was very distraught by this difference and by her friends, and they wanted to do right by Andrea, and they were concerned that they weren't doing right by Andrea, and there was emotional distress in what they were doing. We had another case happening at the same time, I won't go into, we don't have time, that also brought a lot of ethical issues to the table. And so between Andrea's case and this other case, we decided, after a quick review of the literature and not finding much help in the literature to help us navigate these complicated issues we were dealing with, that we should do something about it. So we started the Institute of Burn Ethics in 2015. Since then, we've done a number of presentations, and I've highlighted and put in bold the medical providers that have been involved in those presentations with us. And these are just the people that we listed on the presentations, but we can't do this work without the support of the entire unit. We're very welcome in the unit, and we're very much supported in the unit, and we're very much a part of the team in that unit. So I won't make you read all these, but you can see we've been quite busy thinking and talking about this stuff. So in 2015, I actually joined the American Burn Association. I am probably the first trained ethicist to be a member of the American Burn Association. If you haven't been to an ABA meeting, if those of you, some of you said you worked in a burn unit, there is nothing like an ABA meeting. If you want to see people very committed to the work they're doing, I might use the word obsessed with the work they're doing, you want to go to an ABA meeting. It is really something very special. But it's not just about burn and wound care for them. It's about pain. It's about quality of life. They spend a lot of time talking about their survivor group work. They're concerned about all aspects of the patient. And one of the examples of this is the Libre study being managed by Boston University. You can Google this and take a look at it if you want to see it, but it's an extensive electronic evaluation system that helps burn patients and burn providers focus on the impact of burn on actually their social lives and not just their physical lives. In 2016, only a year after I joined the American Burn Association meeting, the chair of the Ethical Issues Committee knew I was there. She knew I was the only ethicist in the room, and she actually singled me out during the meeting to provide feedback on an issue they were talking about. So I have found, our team to be welcoming, but I've also found the ABA to be quite welcoming of me. So in 2017, I became a member of the Ethical Issues Committee for the ABA. I'm the first trained ethicist to be an actual member of the Ethical Issues Committee of the ABA. I serve as their representative to the Organization and Delivery of Burn Care Committee. Very proud of that. In 2017, we also hired Rosie as our first burn ethics research assistant. So we're sort of asking the question, what do we do to foster an understanding of burn care and burn units by non-providers, and perhaps in particular by ethicists, right? Because there is this strong feeling against burn units in the literature. So we think that we should increase the interaction between burn units and clinical ethicists. Like I and my team do at Metro, we should include ethicists in their interdisciplinary rounds. We asked the American Burn Association in 2015 at the Ethical Issues Committee session, we asked them how many units have ethicists as a member of their team. We think probably, there were several hundred people in the room, we think that probably every unit was represented. The answer was 3. Right, so burn units do not have ethicists generally embedded in their units. We think we should maybe determine the conditions under which an ethics consult is called. And if you saw a few slides ago, I gave a couple of talks at University of Texas Medical Branch Galveston in late July about some of these issues and the lack of literature in burn care and the lack of participation of clinical ethicists in the burn unit. And since then, they have actually developed a system by which there's an automatic ethics consultation that's called when you take into account the size of the patient's burn and their age. And we think that that's great, and we think that we should try to spread that, whatever they're doing down there. And we think we should support scholarly activities addressing burn ethics. We think that there should be more work done in this, and this is what we're inviting you to help us with. Right, decision making is an issue in burn care like it is in almost every other area of medicine. Right, there's this issue with capacity and when do burn patients have it. Do they have it acutely? We don't think that they do, but what implications does it have just not for burn patients, but for other types of patients who have suffered a trauma? The timing of telling patients about certain aspects of their injury is something that we should be discussing. Amputations for patients who lack capacity. And we've had these with patients with burn wounds, but also we've seen a number of these patients with schizophrenia who suffer from frostbite. and they can't understand that their limbs need to be amputated because of the frostbite, and the ethical implications of that, and actually the emotional and moral distress that this poses to the team to try to have to amputate the limb of somebody who doesn't understand what you're doing and why you're doing it. Surrogates and the role of surrogates, especially when we talk about a quality of life for a patient. This survival function, cosmetics, hierarchy that the burn unit follows, burn team follows. Again, quality of life. There are issues with actually living skin donation. So there are some rare cases where burn patients might receive a living skin donation, but it's not the only place where they might do this. They've used living skin donors for breast reconstruction, for scalp reconstruction, for scapular reconstruction, and there are actually no rules and regulations set out for how to manage the donors in particular. They're not covered like they're covered for livers and kidneys and such things. Of course, pediatric burn patients, a lot of things that we can talk about with pediatric burn patients, et cetera, et cetera, et cetera. Right, the list goes on. There's a lot of stuff that we could be talking about in burn units. It's not limited to capacity and autonomy and who gets to make decisions and how those decisions are made. I'm going to send it back to Dr. Khandelwal. I'll sit your chair until you're done.
No. Let's talk about the three big elephants in the room, right? So, paternalism, parentalism, and then coaching, and then my perspective on all of them. So, these all exist, right? And they exist to some extent. There is, some degree of paternalism. You can define it different ways. You want to define, the weak and strong, the new, the old, the soft, the hard, however you want to define it. There's multiple definitions. Sure, that exists. There is paternalism, out there in the world. There is parentalism out there in the world, right? That exists as well. And then we also have this other new concept of coaching, right? And we feel that we do a lot of coaching, in a burn unit. And so what really happens? I mean, how do all of these three play a role in the burn unit? What really happens in a burn unit? Are we paternalistic? Maybe, I guess, right? I mean, call it what you want to call it, but maybe there is a degree of paternalism. Maybe there is a degree of parentalism as well. Maybe there is a little bit of an overlap in there. So maybe that's where we are, right? Maybe we're in this little fuzzy area where there's an overlap. But let's throw in a third thing, and there's actually coaching, okay? So maybe it's one of these, maybe it's two of these, maybe it's all three of these, okay? And then you get that funny, weird color in the middle that we really don't know what it is. And I would argue that that's actually where we are, okay? What happens in a burn unit is not paternalism, it's not parentalism, and it's not coaching. It is a combination of all of them. It's something that we don't have a definition for. It's something that we haven't thought of, but it exists. You can't call it one or the other because it's not. It's its own unique entity of what really happens in a burn unit, okay? Is that approach necessary? I'm going to ask you to just watch this movie with, or this clip. I'll fast forward a little bit.
Answer that question. I'll add. You want answers? I think I'm entitled. You want answers? I want the truth. You can't handle the truth. Those walls have to be guarded by men and women. Who's it gonna do? You, Lieutenant Weinberg. I have a greater responsibility than you can possibly fathom. You weep for son Anjay alone. Kurt for little Reed. You have that much. You have
Not working.
You can't hear it, really.
Well, hopefully all of you remember that clip. Right? He makes several statements during there, okay? Now, while I'm not here to say that I'm like Jack Nicholson or that I am Jack Nicholson or that we're as egotistical as Jack Nicholson, okay? We're not, okay? But there are a couple things that are very similar to what he says and what happens in a burn unit. And those are a couple things. Number one, in the movie, he comes across as a very dedicated, passionate person about the services that he provides. We're very dedicated and we're very passionate about the services that we provide. There's a line in there where he says that, some of the things that, we do are, incomprehensible to you and I may appear grotesque to you. but that's important because you want me on that wall and you need me on that wall, okay? While some of the things that we do may appear grotesque or, God, how could you be so whatever, paternalistic or parentalistic, whatever you want to call it, right? How could you be that way? While we may appear grotesque to you, the bottom line is you need that team. If you had a burn injury, you would want that team, and you would need that team. You wouldn't want anyone else taking care of you. You wouldn't want anyone else taking care of you but that team, okay? And that's the similarity between the two, okay? And that's where that role of the team comes in. So what happens with that team approach, right? Does it really make a difference? And absolutely that team makes a difference, okay? The mortality rate for burn patients now is less than 4%. Take out a subset of patients that you make comfort care, okay? So once again, 80-year-old grandmother comes in with an 80% burn, that's medical futility. We're going to proceed with comfort care measures. Exclude that group of comfort care, that mortality rate drops at 2%, okay? Only 2%. Our children, they don't miss a year of school. I cannot tell you the last time I've had a burn patient or a burn pediatric patient miss an entire year of school. They don't. They go back to school. Our patients go back to work, okay? A lot of times they go back to work. Not all the time, but a lot of times they go back to work. And quality of life, okay? Quality of life is actually good. If you look at a subset of pediatric patients, their quality of life that they report is comparable to their peers who don't have a burn injury. Okay, they recover from this injury. They're resilient. They recover from this injury, and they have a quality of life. Adults, sure, granted, short-term quality of life is diminished. But when you look long-term, they only report a 9 to 13% comparative decrease in quality of life compared to their peers. And once again, that's depending on size. But it's actually not that bad, right? It's kind of similar to that, to this group of patients that are, that have spinal cord injuries, right? We all think that their quality of life is going to be horrible. But we all know the literature, right? They actually, if you talk to them, what do they say? We're glad to be alive, right? We're happy to be alive, and I do have good quality of life. And it's the same thing with these burn patients, okay, with our burn survivors. And keep in mind, we call them survivors. They're not victims. They're survivors. We will never call a burn patient a victim. They're not victims. They're survivors. They're all survivors. And as Monica said, actually, they're now burn thrivers. I guess that's the new term that we're going to use. Okay? So what about ethics in burn care? So we welcome ethics involvement, as Monica said. We welcome everyone. Okay? We want more members of the team. We know that the more members of that team, the better care the patient receives, and that's ultimately what we're interested in. That's ultimately what we want. Okay? But we have to keep an open mind. We need to be open to your ideas. You need to be open to our ideas, right? That's with everything that we do. We have to keep an open mind because there's things that we can learn from each other. There's things that we can understand from each other. We need to establish criteria for ethics consultations. We need to establish ethical standards in burn care, okay? But most of all, right, we need to work together, okay? And the best part about working together, as Monica pointed out, there is a wide open space, as you can see from that last panel. There is a wide open space. We are free to create what we want. And that's what we need to do. We need to kind of forget about forget about some of the stuff that's already been kind of skewed one way or the other way. Let's start from a clean slate. Let's work together and let's come up with some of these standards. Let's work together and establish a better relationship between burn and ethics. Because once again, ultimately that results in better patient care, and that's ultimately what we want. The last thing is I'm going to give a quote from Khandelwal, who actually happens to be the grandfather for one of my mentors when I was in burn training. So out of suffering have emerged the strongest souls. The most massive are seared with scars. And if you have any doubt as to the strength of a burn survivor's soul, talk to Andrea. Okay? Thank you.
Some of my final comments, I think Dr. Khandelwal and Dr. Gerrek covered very well, but this is from my perspective, so I'm going to mention them anyway. I have to be honest with you. When I first learned that there was such a disconnect that exists between the ethics community and what really takes place in a severe burn situation such as mine, I was really surprised. I asked, how is it that they don't know what's going on in here? And furthermore, why hasn't anybody looked into this for so very long? It's complicated. There is a very slippery slope as to at what point do you give a severely burned patient complete autonomy? How can the doctors be absolutely certain when a patient who is so heavily medicated and still experiencing unthinkable pain has the capacity to make a decision between life and death, or if their families can make that decision for them? So here I am, 3 years later, over 40 surgeries in, with still more ahead. Is any of this ideal? Not by a long shot. It is still a struggle for me every single day. I question my faith at times, wondering what the overall greater purpose of any of this struggling and suffering could possibly be. But I can tell you honestly, I'm happy. I'm living as full of a life as I possibly can. I thank God every day that my family went against their initial instincts and what they were correct in thinking would have been mine, and chose instead to let me live. I'm asking everyone here to please take a much needed look at what's really taking place in burn care today. It is long overdue in time to reevaluate a belief system that has been in place now for decades, surprisingly without ever really being challenged. I realize this is by no means a cut and dry issue, but it is one that calls for the consideration that burn patients and their families absolutely deserve. Thank you all very much for being here with us today. Thank you.
So we'd like to open it up for comments and questions. Yes.
Couple comments and questions. First, if you'll forgive me, at these meetings, which have gone on for a long time, I usually find myself saying, okay, what was the one session or one part of the session that somehow made it alone worthwhile coming? For me, this is this session, and particularly your comments, Andrea. So
Thank you.
Thank you for that. Also, just wanted to note that there are some things that I didn't understand. I'll just list one of them, like the Reiki that you referred to.
Yes.
I'll come back to that later.
Okay.
Just a fill in for fun. My real point is that I actually see patients at Walter Reed. I'm a psychiatrist there. And as you were talking about expanding this model, which it struck me that for trauma patients in the military, such as those who've seen terrible things, people right next to them, heads blown off and spell them out and so on, and then have the physical stuff on top of it, like needing amputations and having head trauma, it strikes me that there's, for that group particularly, all that you've said makes great sense for that group and others. And so I do a here to your notion of spreading this notion, and I'll speak with you afterwards how I, from another role I have as an editor of an ethical journal, I'd be interested in furthering your interest.
Thank you.
Thank you.
I just say ditto. One of the reasons I come to this meeting is to say, what am I going to take back to our ethics consultation group at home? And this is what I'm going to do that to them. And what I also see here is it's exceptional circumstances. It's not what ethics has to give to you, it's what you have to give to ethics. I think the rest of the hospital, every other unit, can learn from this. Autonomy, has gone out way beyond what it was meant to do, maybe because we're so incapable of doing anything about justice or any of these other issues, so we go full steam ahead with autonomy to the detriment of our patients. And this is, I hope we can invite you to Columbia and give this talk.
Thank you.
I'd be happy to.
I have a question for Dr. Khandelwal.
Yes.
What was your decision when you were in medical school to go into this type of medicine? What was your passion about it that led you to where you are today? Why this?
So I think for me there was, I would say, three things. Number one, growing up as a kid, I was always an oddball. So everyone drank Coke, and I had to drink Tab. Or for those of you who remember, Ale-8. Okay, so yeah, everyone else drank Coke, I drank Ale-8. Everyone else liked these normal fruits, and I like pomegranates. Being an oddball was one, right? No, most people don't go into burns. So number one, being an oddball. Number two, I did my medical school training in India, and as part of those degree requirements, you have to work there for a year. And I distinctly remember, without going into too much detail, working with several burn patients, and I felt that in developing countries, burn care is significantly lacking. And I remember being instantly drawn to that, thinking that, oh my gosh, this is just, I mean, this whole concept is just fascinating, what really happens to these patients. And then as I continued my training here in the U.S., the one thing that drew me to burns, in addition, once again, maintaining my oddball nature, was the team. I think it is by far the greatest privilege, the greatest honor to work with a group of individuals that I get to work with the type of patients that I get to work with. It's just nothing short of phenomenal. It's a beautiful team to work with. It's a beautiful group of people to work with.
I thank you.
You're welcome.
Good question.
Yes.
Hi. You talked a lot about the culture and practices within your particular unit. Would you say that that's fairly representative of how burn units function across the country, or are there maybe things that you think you do well that you'd like to see done at other places, or vice versa?
So I think all burn units are different. There's a lot of the stuff that we talked about here that are done at all the other units. The way we feel about our patients, the way we are engaged with our patients, and the approach to patients, I would argue is similar across probably 99% of all verified units and probably a good 80-85% of non-verified units. Granted, we do a couple things a little bit differently than other units. I'm sure there's units around the country that do things better than we do. As with anything in medicine, this is a constant learning process. This is why we have an organization, so that we can constantly learn from others and improve our practice. But this is not just the viewpoint of us. This is a viewpoint of burn centers in general. And I think Tammy, our nurse practitioner, she's been in burn care for a long time. She's visited a number of other centers, and she could probably attest to the same.
I would certainly agree. We all have that philosophy, and that's what we strive to. We all maybe do things a little bit different, but we all have that same goal in mind.
So one of the problems, though, with burn care is that not everybody treating burns in a hospital is trained to treat burns. Right? There are very few fellowships in this, and so this is why there aren't that many verified units through the ABA, because in order to be a verified unit through the ABA, you have to have a fellowship-trained burn physician, and there aren't that many of them. And one of the concerns I have as an ethicist is that people who are writing about burn care are writing about it from the perspective of somebody who is working in a facility that does not have a fellowship-trained burn physician and thus doesn't have this team unit. So the patient's being treated by a plastic surgeon, maybe a physician who isn't as familiar with pain control in burn patients, right, and these kinds of things. And one wonders if medicine shouldn't change the way it looks at who's permitted to provide burn care and who isn't. But then we'd have to increase the number of fellowships in the country too, right, so we can get enough trained physicians. Hillary's over here.
Yeah, so just thinking about your role as an embedded ethicist, Monica, and how you drink the kale smoothie but not the Kool-Aid, can you kind of elaborate on the moments where you find yourself disagreeing with the team and what those issues look like?
Yeah, so I have to tell you, so jokingly, the soon-to-be former director of the burn unit had a retirement party last Saturday, and they had memory cards. And one of the things I wrote on the memory card was, every time, so we have some master's students here, whenever they go in, if he's the attending on call, he will say to them, we'll be talking about some patient, and he'll say, see, this is why ethics is so important. This is why we have to have ethics here, because all of these issues come up. And I wrote on the card, that you say this at every meeting, and yet you've never called an ethics consult, right? But I'm there every week, and he has my cell phone number, and we have a 24-hour, they can find me, right? It's a little different than somebody who doesn't have an ethicist embedded in the burn unit. But I don't know that I've ever disagreed. We talk about ethical issues independently of patient care that are a lot, he is, I would just say, to give him credit as a surgeon, as a burn surgeon, he's a lot of fun to talk about ethics with. Like, he will let you...
So I don't know anything about it.
He will let you question him and call everything he does into question. And so will Dr. Yaller. We've had some fun with Dr. Yaller, too, with some of these questions. So they let me question them, but when it comes to patient, like a particular case or a particular patient, I don't know that I've ever disagreed. There have been some where if I had been the surgeon, I might have done something differently. But I wouldn't say that it's ever been the case where I thought, man, they should not have done that and they didn't listen to me. They're very thoughtful, and it's in part because they have this team approach, right? That the nurses, they never make an end-of-life decision without a nurse, like without nursing input, right? The doctors don't come in and say, we're stopping or we're not stopping. All of these decisions are made as a team. And so there are a lot of people thinking very deeply all the time about what's happening with a patient. So, I mean, most of the stuff that I contribute at the burn rounds are, okay, let's make sure we know who the surrogate is. And, you know, some of these complicated cases, you know, there was the gentleman, sadly, a number of years ago who was in the car accident. We weren't sure if he was in a suicide attempt or not. And, you know, second wife, adult children, and any chance of survival was going to require 4-limb amputation. 4 limbs, right? So if the guy woke up, he was going to be without 4 limbs. That's hard. Right, and frankly, there are times that they turn around and they ask me, and I'm like, I don't know what to tell you. You know, I mean, what do you say in that situation, right? If you want to give the guy a chance at life, which is what the wife wanted to do, you have to start down this road. He could die at any point down that road. But if you listen to the kids and you don't attempt it, then what, right? I mean, they're not, like in so many other areas of medicine, they're not easy. So I don't know that I've ever actually flat out disagreed. I mean, I participate in the conversation, I provide the recommendations as I can, but it is this collegial, this isn't made up, like this is just how it actually works.
And I think with every team meeting, right, I mean, everyone contributes information, right, so you can't really call that whole process disagreeing, right, because everyone's going to have their own points. Some of them may clash or, you know, not be completely congruent with, you know, all the other plans, but ultimately you have a plan that comes forward, right, but that plan that comes forward is not mine. It's not hers, it's not Tammy's, it is actually the team's, right? So yes, there is discussion in between, but that plan that comes forward is a plan that comes together from the team. So I would say that there really isn't,
I think if I disagreed, you guys wouldn't do it. If somebody flat out disagreed was going to happen, there'd be another lengthy conversation, like nobody's moving forward unless everybody's feeling comfortable with it.
So what I'm hearing is your role is often to just ask the questions that spur the conversation and sort of the team approach that ultimately gets decided upon.
But sometimes, like with the nutritionist, I'm beat to the punch, right? Because she was sitting before me at the table, and so they got to her with the question about the benefit-harm ratio. I'm like, yeah, that's a good question. You know, so I just sat back in my chair and, you know, we talked about it.
So what happens if the team has a decision that the family absolutely disagrees with? How do you handle that? The patient has no capacity. Family feels one way, team feels another way. What becomes the outcome?
So it's dependent on the situation, right? The hospital as a whole, and not just in the burn unit, right? The hospital as a whole does not want family to leave feeling their voice wasn't heard and that this was not a collaborative effort. So we're called often in those situations, right? I mean, those of you who do ethics consultation know, right? You get called, something's going wrong in the hospital. You're not getting called because everything's good. And it's often because there's a patient team or medical team family disagreement about what should move forward. So we try to give the team tools to have a conversation with the family. If that doesn't work, we'll ask for a team meeting to include the family and try to get everybody in the room and to come to some sort of agreement that everybody's happy with. Oftentimes these things are just communication issues, right? The team and the family, it's like in Andrea's case, everybody wants what they think is best for Andrea. You know, she can't speak for herself. Everybody wants what's best. They might disagree about what's best in a particular situation. So the idea is to get everybody in the room together to talk about what they think is best and then to come to some sort of solution. If we can't, I mean, if we just absolutely can't, then unfortunately there are legal measures that one side or the other might take. We really try to avoid that, though. That is not the road we want to go down. And this doesn't come up in the burn unit, right? We get this from our other units. It doesn't actually come up because there is this constant communication and constant collaboration between them. I've never been called about this issue in a burn unit. Never.
So this is more of a statement question, but I really appreciate your comment about team-based approach in the family, and that you establish as a team. And I would be remiss to not mention that someone who's part of your family, who's also part of my, he's a member of my church and my church choir, and he's very much part of that family that I have, and his probably just as much as any of your family as well. And probably can't stand him at times, but you know, I think that's a really good analogy, a choir and church choir for what you guys are doing, in that a choir takes a certain amount of rigor and attention towards there's a scientific component to it, I guess, in terms of the composition and learning the material, but there's also that artistic portion. And when you add a faith-based element to it, it makes a dynamic that I think resonates with what you all are saying. And also, just to make another connection, I mean, every time we have practice, he always says, pray for this person that just entered the burn unit, and you know, think about them. And so it has a lot of analogies, and I just want to just throw that out there and mention that.
Thank you.
So I'm Rosie. I'm the student research assistant, and I've had the privilege of working with these people for a while now.
But I'm going to interrupt her. If you want the expert in the room on the burn ethics literature, it is this person sitting here. She has read every article ever written on burn ethics. So thoroughly has documented it. So she,
I get paid though, don't worry.
Yeah, she is the expert.
But the literature really lacks substantially patient perspectives. And for me, you know, I was close to tears hearing you, Andrea, share your story. And it's just amazing. I mean, I don't have words for it. But I'm curious, as someone who has read the literature a lot, and the one patient voice that is really expressed in the literature, and the one perspective is Dax's. And we're close to, geez, like 50 years later. And I think we all know that name, but people don't yet know your name and so many other burn survivors' names. And I've never asked you, but I'm curious, what did you think how did you feel, or what were your thoughts? What went through your minds when you first started hearing about the Dax case and that story? And did it feel congruent with your own? Were there things that you understood about it, or that, you know, what are your thoughts?
Sure. Well, when I first heard about Dax, you know, of course, I was very interested in who is this man who got the privilege to live and is going around talking about, you know, how he was treated, and he had the right to autonomy and wasn't given. So as I looked more into his story, this was, I believe, back in 1973. Okay, so burn care was completely different. And it was heartbreaking to see some of the video and hear what he went through. I did not experience that same environment, so it's hard for me to answer that on an equal ground, because what I experienced 44 years later is completely different than what Dax had experienced. So my heart does go out to him. I believe he has a very compelling story for 1973. You know, it's now 2017, so you know, it's a completely different environment. And again, as I said in my final comments, I was very surprised that the ethicists don't know about what's really taking place. So that got me really excited to be a part of this, to say, hey, you know, I know the pain he went through, but probably not as much, because pain management has you know, been developed so much more in all these years. So while I do see very much the struggle he went through, I don't want to say it's irrelevant, because of course his story is not irrelevant. But today, it is not what's going on in burn care. So that's kind of, I hope that answered that, Rosie. I don't know.
It does.
Yeah.
Thank you.
You're
I mean, the
welcome.
bulk of the literature that I've read has definitely been about burn rehabilitation and therapy, and a very holistic view of that. And so it's been interesting reading the Dax stories and seeing that nowadays medicine has progressed a lot in that direction of thinking about quality of life. And
Sure.
so thank you.
So we've heard a lot about process and communication. Unfortunately, you think we should do it? We're over time already. I think we can just come up afterwards, no? Okay.
Yeah, I think people are ready to go.
So yeah, unfortunately our 90 minutes allotted to
Needed
process and
longer.
communication
Always.
have ended, but I'm sure that the panel would be more than happy to continue communicating and talking with you afterwards. So with that, we should conclude.